Can the glenoid labrum be seen on ultrasound? Magnetic resonance imaging is usually considered the reference method for evaluating the glenoid labrum. But what if MRI cannot be performed? In this video, I will demonstrate how different parts of the glenoid labrum can be visualized during a structured shoulder ultrasound examination. When examining the posterior labrum, the easiest position is with the patient sitting and the arm resting freely along the body. The examiner sits behind the patient. The probe is placed slightly below the scapular spine, over the glenohumeral joint, and held horizontally. Internal rotation of the arm may help to improve visualization. The patient can be asked to rest the forearm against the abdomen. In this position, we obtain a posterior view of the glenoid labrum. We can identify the bony glenoid, the labrum extending from its margin, and more superficially, the thin layer of the joint capsule. The humeral head and the articular cartilage covering it are also visible. In every position, the labrum should be evaluated dynamically. Labral abnormalities are often more evident during movement. When examining the posterior labrum, rotational movements of the arm are particularly useful. To visualize the superior labrum, the probe should be positioned at a soft point located slightly medial to the medial edge of the acromion, approximately midway between the scapular spine and the clavicle. One of the main difficulties in imaging the superior labrum is the acoustic shadow produced by the acromion. To overcome this limitation, trapezoidal imaging can be used, or the ultrasound beam can be angled to obtain an oblique ultrasound beam. A convex probe may also be used. The probe should be adjusted so that the labrum is positioned near the edge of the image rather than in the center. In this way, obliquely directed ultrasound beams may allow us to look underneath the acromion. In many cases, the attachment of the long head of the biceps tendon can also be visualized. If the assessment of the biceps anchor is important, external rotation of the arm often improves its visualization. We can identify the bony glenoid and, on its extension, the superior labrum. In this region, labral pathology may sometimes be visible even at rest, but dynamic examination with rotation, abduction, and adduction of the arm may further improve detection. Assessment of the anterior labrum is more challenging. This is mainly because the scapula and the glenoid are oriented obliquely relative to the thoracic wall. The examination is easier with the patient in the supine position, which stabilizes the scapula against the examination table. The arm is placed alongside the body, usually in slight external rotation. In this view, we can identify the bright echo of the bony glenoid margin and superficially the triangular shape of the anterior labrum. It is important to remember that not the entire triangular structure corresponds to the labrum. Part of it represents the middle glenohumeral ligament. In the evaluation of the anterior labrum, dynamic assessment is particularly important. During rotation of the arm, abnormal mobility of the labrum may sometimes become visible. During internal rotation, the labrum may slide medially from the glenoid margin, while during external rotation, it may return to its normal position. Trapezoidal imaging may also improve visualization of the anterior labrum. However, the labrum should again be positioned near the edge of the field of view. Pay attention to the direction in which the probe needs to be shifted to improve the image. In some cases, slightly increasing pressure on the medial side of the probe may also enhance visualization. When examining the inferior labrum, the patient remains in the supine position. The arm is placed in maximal flexion and abduction, with the arm elevated above the head. In this position, visualization of the inferior labrum is usually relatively straightforward. We can identify the bony glenoid and, extending from it, the inferior labrum. Superficially, we mainly see the joint capsule. The anterior band of the inferior glenohumeral ligament lies anterior to the probe position, while the posterior band lies posteriorly. In the next part of the presentation, I will show several still images obtained during this examination with the relevant anatomical structures labeled. For those interested in a more detailed technical description of this examination protocol, A link to the related scientific publication is provided in the video description. The article is titled Clock Phase Sonography of the Glenoid Labrum, a Pictorial Technical Protocol for Patients Ineligible for MRI or MR Arthrography, published in the journal Diagnostics. If you found this material useful, I encourage you to share your questions, clinical experiences, or suggestions for future topics in the comments section. Thank you for watching.